Thank you for the opportunity to present. The authors have nothing to disclose. Trauma remains a leading cause of global morbidity and mortality, and pre-hospital factors may influence trauma patient outcomes. This study aims to identify the clinical, epidemiologic, and geographic patterns of trauma in Maine, and to discern the pre-hospital predictors of morbidity and mortality amongst trauma patients in Maine. We hypothesized that pre-hospital clinical conditions and pre-hospital times would predict trauma patient survival, and that adverse weather conditions would negatively impact trauma patient survival. We conducted a retrospective cohort study of all trauma patients seen at Maine Medical Center from January 2015 through January 2018. The study was conducted at Maine Medical Center, which is a rural level 1 trauma facility, and we obtained our clinical data from the trauma registry housed at Maine Medical Center. We obtained our weather data from the National Oceanographic and Atmospheric and Administration database, also known as the NOAA database. We included all trauma patients seen at Maine Medical Center and conducted a sub-analysis of all patients with a GCS of less than 10, as well as those with a systolic blood pressure of 90 or less. We conducted inferential and descriptive statistical analysis, including building a regression model. Also, we created a geospatial map to identify trauma hotspots in Maine. We captured 442 patients within the 3-year period. The median age was 52 years, and most patients were Caucasian males. The most common injury mechanisms identified were falls and motor vehicle crashes. And we identified that in terms of injury severity, 12% of our population had pre-hospital hypotension, 52% had a GCS of less than 10, 56% had an ISS greater than 15, while 9% of our patients had arrested in the field. The two maps to the left show the trauma hotspots with the New England view, with the map in the middle highlighting the key trauma hotspots from a more zoomed in perspective. Portland has a key hotspots here because Maine Medical Center is housed there, but there are 3 outliers further up north, and these are Augusta, Bethel, and the Dover-Foxtrot areas. We also have another outlier in the adjacent state of New Hampshire, mainly in the Dover and Portsmouth areas. The median time on scene was about 15 minutes, and 54% of our patients were transferred from an outside hospital. The median time to definitive care was 129 minutes, and ground ambulance was the most commonly used method, with 85% of our patients using a ground ambulance. We identified that patients with a field GCS less than 10 had a higher odds of ICU admission with an odds ratio of 2, while patients who had an ISS greater than 15 were more likely to be admitted or taken to the OR with an odds ratio of 2.9. In terms of mortality, we identified that being injured during warmer weather had lower odds of in-hospital mortality with an odds ratio of 0.9. And patients who had hypertension in the field, that was the single greatest predictor of ED mortality with an odds ratio of 11. Patients who had an ISS greater than 15 had a lower likelihood of had a higher likelihood of in-hospital mortality with an odds ratio of 3, as the patients who had hypoxia in the field. To conclude, in our rural catchment area, amongst patients who were severely injured, colder weather adversely affected trauma patient mortality. Geolocation did not predict trauma patient mortality, and field hypotension, hypoxia, and a low GCS, as well as higher ISS, were all identified as clinical predictors of mortality. Thank you. And to answer the moderator's question goes thus: I noted the while field hypotension, ISS greater than 15, and field hypoxia predicted hospital mortality, hypothermia was not mentioned. Did you investigate this variable, and did it contribute to poorer outcomes? Unfortunately, with the data that we did analyze, pre-hospital patient temperature was not included in the data set. However, the patients did have a temperature in the ED. The research team did feel that ED temperature would not accurately reflect patients' pre-hospital temperature. So as at this point during this analysis, we did not include, we do not have temperature as a variable to predict trauma patient outcomes. I hope that answers your question. Thank you.